Thank you for joining us for our live virtual MDA Engage IBM event. My name is Nicole Petrowski, and I'm the Community Education Specialist in the Communication, Education, and Insight Department for MDA. I hope many of you were able to join us yesterday as we kicked off our 3-day seminar with a fantastic presentation from Dr. Mozaffar. The symposium has wonderful information that is devoted to the inclusion body myositis community, and I'm glad to have you all with us today. The seminar today is part of our larger MDA flagship community education series, which began in 2018 and focuses on bringing the neuromuscular community together around education and social opportunities. Here's a list on your screen of some of our engaged seminars we will be hosting this year. We are also currently in the process of rescheduling our spring events, so be sure to check back on the MDA Engage section of mda.org for updates on other virtual and in-person events this year. Just like everyone else, MDA is very aware of the pandemic affecting all of us right now. Therefore, we have created a resource page dedicated to COVID-19 resources and recommendations for our neuromuscular community. Please visit mda.org/COVID-19 for up-to-date information, participate in our MDA patient and caregiver survey, and view important recordings such as our Facebook Live events surrounding COVID-19. Now, I have just a few housekeeping items to go over before we begin. We are recording today's event, and we will be posting it to mda.org website for on-demand viewing down the road, and to ensure those who weren't able to join us today are able to access this important information. For those of you who are joining our live event, please know that all phone lines have been muted, and we will be having a Q&A session at the end of the presentation. So please utilize the Q&A window to type in your questions. If you hover over the bottom of your screen, a tray of icons should appear, and if you click on Q&A, that would be the feature where you can enter your question to host. You don't need to wait until the presentation is over before you submit your questions. If something comes up during the presentation, please feel free to type it in and share those. Before we begin our seminar, I would like to say a special thank you to our chair, Dr. Tassim Mozaffar from the University of California, Irvine, for all of his hard work in helping to assist this symposium. I would also like to thank Elise Qualley, the Director of Community Education and Insight Department, and our Chief Privacy Officer for MDA, who is assisting me with behind the scenes of this webinar. Finally, I want to say a thank you to everyone in the IBM community who's joining us today. At MDA, community education is important to us, and we are happy to be able to offer experiences like this and thankful to have everyone joining us today. Just a reminder, we will be taking questions after Dr. Alfano's presentation, and we will get to as many as we can. To kick off our IBM Symposium, I want to introduce to you our presenter today, Dr. Lindsay Alfano. She is a physical therapist with expertise in the care and evaluation of patients with neuromuscular disease, including outcome measure development, evaluation, and administration. She plays an integral role in designing and planning clinical trials in the Care Center for Gene Therapy at the Abigail Wexner Research Institute at Nationwide Children's Hospital, and in partnership with industry-sponsored trials as well. Dr. Alfano has completed natural history studies of available outcome measures for patients with inclusion body myositis, and her research goals focus on promoting optimal assessment tools to measure change in movement abilities while minimizing the burden of testing in patients with neuromuscular disorders. And with that, Dr. Alfano, I will let you present.
Great, thank you very much. Welcome to everyone, and thank you for joining us today. I'm really excited to talk about this topic. I wanted just to have a bit of a disclaimer before we start. A question I often get is, you are a physical therapist working at a pediatric institution, so what is it that you're doing working with patients with IBM, which is an adult disorder? And I do think that's a fair question. I'd say our clinic is unique within our children's hospital, that we see patients from birth through adulthood. Anybody that has a neuromuscular disorder that comes through our door, we evaluate and treat across the lifespan. So don't let the pediatric institution fool you. We are kind of a across the lifespan sort of clinic. So with that, we'll move along. I wanted to first just present some disclosures. As Nicole mentioned in the intro, I do work for an international consortium of neuromuscular physical therapists that does provide some ongoing consultation with the industry sponsored trials to look at outcome measure selection, training, quality control across their clinical trials. And then do have some other training grants through my institution and have served on some ad boards as well. But none of these should in any way bias my talk, but I did want to present those before we move on. So first, I just wanted to make sure that we're all starting on the same page. So what exactly are we talking about when we mention outcome measures? This is a really broad category. It's really anything we're using to measure change over time. So moving to the next slide, we kind of group them into certain categories. So, these can be used as part of clinical care, just looking at, how conditions are affecting patients, as well as in clinical trials, as we've already kind of alluded to. So these can be biomarkers where you may have, had blood draws or MRIs or EKGs. All of these sorts of things can be used as outcome measures and are talked about as outcome measures. We also look at strength measures, measuring certain functional activities, participation activities, or your ability to participate in social events, those sorts of things, as well as just patient-reported quality of life or other health indices are kind of the broad categories that we look at. So again, when thinking about outcome measures, I like this cartoon because I think the main question that I get from physicians I work with or from industry sponsors is, okay, we're gonna do this trial, or okay, I have this patient, what outcome measure should I use? And it really depends. So there's not just one tool that works for everyone. There's not a magical outcome for patients with inclusion body myositis. And so I think my biggest education piece for those looking to measure anything or a person or disease progression is to really think about it critically and try to plan as much as possible to make sure that we're able to actually measure what we think we're measuring over time. Another question I get is, okay, well, can we just jump to the clinical trial? There's all these outcomes that are available. I've heard of the 6-minute walk test. Everyone uses it. Let's just do a clinical trial. We'll throw the 6-minute walk test in there and we'll see what happens. And I'm hoping by the end of this talk, you'll have some insight into the mindset of kind of a clinical trialist or, a physical therapist you may see in clinic that's having you do a fair number of tests to measure disease progression and kind of understand why we're doing that. And it's not just for fun. I know we get a lot of, as physical therapists, there are a lot of nicknames for us, but really the goal is to understand as much as possible about a person, about how the disease is affecting them so we can make true scientific recommendations versus just guessing. So again, moving through these outcome measures, I think one of the things we need to keep in mind is we would all love, I think, for life and clinical trials in particular, to move from point A to point B in this straight line. But I think our current situation, and this, as Nicole was mentioning, COVID-19, demonstrate kind of the real path that life takes. So it's uncertain, it's circuitous, it's non-linear. We have good days, we have bad days. And so we need to plan for all of these when we're selecting outcome measures and selecting tools that we're going to use to measure disease progression over time. So again, what are natural history studies? Some of you may have heard this term, some not. These are really studies that are conducted, as I have at the bottom here, prior to or in parallel with development of investigational products. The goal is really to understand as much as possible about a condition and how that condition affects people. These are non-treatment trials, so it's just kind of observational prospective studies looking at different outcome measures. We may not know exactly what we're looking for, so we may kind of throw a bunch of tests at a person to see, or a group of people to see what works, what doesn't work. Sometimes these are used to identify the cause of a disease, so figure out biomarkers that could be associated with disease severity or help with diagnosis, or help to understand when a disease may be in a flare-up stage, as can happen in some muscle diseases versus more of a stable state. So gaining as much of that background information as possible. It can also be used to really understand just the global effects of a condition on an individual person as well as the group as a whole. So that could be in terms of muscle strength and function, looking at other organ systems. So is it just skeletal muscle that's involved, or is cardiac muscle involved? Is there a pulmonary aspect to this disease? Does it affect the brain? All of these are important to know before we jump into a clinical trial, so we know if the things that we're seeing are truly expected or if they're new side effects that are unexpected. It's also important for us to know how fast or slow we would expect a disease to progress without any treatment. And is this the same across all people in the group, or are there certain subgroups that may be more quickly progressive or slowly progressive? So really, as I've said, these natural history studies, the goal is to give us as much information as possible so we can be as prepared as possible for clinical trials in making clinical care recommendations. So again, going back to that original question, so why can't we just jump to the clinical trial? So we have to really understand what is typical disease, or what is typical for that condition, to prove that an investigational agent is working. So you, as a person with inclusion body myositis, or the caregiver of a person with inclusion body myositis, understand that disease. You live it every day. You know, upside down, inside out, exactly what that disease entails. But you also know your path with that disorder. The FDA and other regulatory agencies may have heard about this. They may have read about it in textbooks. They may have seen some journal articles, but they don't know what the disease is. They want to know what that variability within the disease looks like, but they want kind of proof versus a group coming and saying, yes, we have this investigational agent and these patients are better than they were before. They really need to understand what does that disease look like? And that is something that they want to know, with or without a placebo group included in a clinical trial. There's often a lot of talk about whether a placebo group is the same as a natural, untreated natural history population. But it's thought that those placebo groups are receiving more care than they would naturally or with standard of care. It's usually, a lot of times you'll see your specialty clinics once or twice a year, and you may be seen weekly or monthly as a result of a clinical trial. So your standard of care may be improved. So while those placebo groups are important in looking at the differences between a treated and untreated cohort, they're not the whole picture, and regulatory agencies want that whole picture. And as I'm kind of dancing around, really their goal is to understand the treatment effect and kind of protect us all, make sure that we're getting safe compounds that are proving to be efficacious. And they really want that treatment benefit to outweigh any of safety risks or side effects. So knowing what the expectations for a disease are really critical for them in that decision-making process. Side effects like headaches may be worth, small improvements in function, but larger side effects with organ system involvement may not be worth the potential treatment benefits. So that's what natural history studies help us figure out. So as I'm kind of talking about, we're trying to find the balance for these clinical trials and in clinical care. So we want to be able to find the signal through the noise. There's variability in everything we do. A lot of the outcome measures that I'll talk about are variable, so we'll always have kind of these mean performances over time or average performance. And we see variability in different patient populations. And so we need to know what is an expected average group performance, and then how much variability is normal, to try and tease out whether a compound is performing as we would expect or causing an improvement. Or conversely, if you're being followed for clinical care, if you're progressing as we would expect, or if there's something else going on that the physician or the physical therapist needs to help figure out. So people are different. The same condition can be quite variable across people. And then, as I've kind of mentioned, that variability really makes finding the true signal challenging. So I wanted to put an example here. Again, thinking about clinical trials, and one of the questions I often get from patients is, why can't we just enroll more people, or why are these inclusion-exclusion criteria so strict? And so I wanted to kind of lay out the pros and cons of a study enrolling strict inclusion-exclusion criteria and those with more open criteria. So the stricter your criteria, the lower the variability in your group, because everybody's almost the same. You're likely to find a signal if it exists, because again, you've got that reduced variability. It can be really hard to recruit though, because you're looking for 5 patients in a rare disease that may meet these strict criteria. And then the results that you find from your study are likely specific to that very specific cohort. Conversely, if you have an open enrollment sort of trial, you're going to have a lot of variability. There's going to be a lot of noise that could potentially cover up any signals or treatment benefit that may exist. You're likely to quickly enroll, which is a benefit. If you do see treatment results, those are likely easily generalized to the larger population. But again, you may miss a signal that exists because of the variability in your group. So again, it's finding that balance between strict enrollment criteria, but enrolling as many people as possible so that we can see any treatment that benefit that would exist, to get that treatment approved and then to the market as quickly as possible. So these are all of the things we're kind of thinking about as clinical trialists working in neuromuscular disease and these rare diseases. So natural history studies, again, another goal is really to allow us to control as many of these variables as possible to get to that answer as quickly as possible. So it helps us understand the disease progression, and again, across a larger group, so not just the individuals we follow in a clinic, but likely these are multi-site trials, so we get larger patient populations and we can really understand the variability in that population. But what's also important is that we're looking for meaningful outcome measures. So it's whether you can smile a little more may or may not be meaningful to a patient population. But if you couldn't get out of a chair and now you can get out of a chair, that might be huge. So this is an area where in natural history studies, the patients are empowered to give us ideas of what's meaningful for them. We get to listen to you and hear which things are challenging, which things are not challenging, what would be huge and a game changer if you were able to do that task a little bit easier. So that we don't have to guess. We're choosing things that are meaningful and likely to motivate patients to perform these things. We're also looking for things that are likely to be impacted by the treatment. And it helps us understand if we're expecting change over time or if we're expecting things to stay the same over a period of time. And as I've said before, really the most important is to understand how these outcomes change over time or don't, so that we can compare any clinical care or research participant to that expected natural history. So the goal is really to fast forward. Again, thinking about a person that's choosing outcome measures, a sponsor who's planning a clinical trial, a multidisciplinary clinical care team that's trying to figure out which outcomes are really meaningful for their patient population in terms of equipment prescription, making any predictions in terms of, use of wheelchairs or those sorts of things. There are a lot of things that we're considering. This is not an exhaustive list, so this is just some of the things that are going through my brain when I'm talking to people about outcome measures. So there's patient considerations. Tests that work in a pediatric population may not be ideal for an adult population, and vice versa. I think often, again, working in a children's hospital, we do see a fair number of children, and there are often clinical trials where they're applying adult outcomes to a pediatric population, which is always interesting. Thinking about the subgroups in your inclusion-exclusion criteria. So who would be in your clinic, who would be in your clinical trial, and what's best to measure them over time. So are you looking at patients that can walk? Are you looking at patients that aren't walking in their arm function? Again, I've talked about a little bit about that clinical meaningfulness, but that's really an important criteria for these outcome measure selections. So what is truly meaningful to patients that's really going to make a big difference if it changes, and then monitoring that. And also the variability in patient performance. So we're all variable. If you have to travel to a clinical trial site, if you have to travel quite a ways to get to your multidisciplinary clinic, your performance may not be your best. It may not be what you could do at home in your comfortable environment. And so we need to consider those things and try to reduce any variability that could be associated with that, which is not an easy task, but is something that we often think about. There's also, if we're planning a clinical trial, there are considerations related to that study that are important. So what is the mechanism of action of the drug? Is it a targeted, specific muscle growth, targets muscle growth, or is it a more systemic IV injection that would go throughout the body? The outcome we would select is likely very different for those sorts of studies. What is the outcome of the treatment? Are we expecting it just to maybe build a little bit of muscle? Are we expecting it to be, a game changer where you could have improvements or regain lost skills? The outcome you would select would be very different for those studies. And then how long is the study? Usually some of the early studies that are looking at safety are shorter. So what can we measure in a 6-month time frame versus a longer 2 or 3 year study? The amount of change you can see across those time periods is quite different. And then the actual outcomes also have kind of their own considerations. So outcome measures can have different rating scales. They can be on more continuous versus ordinal rating scales. They can have what we call floor and ceiling effects. A floor effect being if the skill is too hard for most of your cohort, then everybody's going to get a 0. So you're not going to see, even if they had improvements of strength or in strength or function, you're not going to see those because it was too hard to start with. Or a ceiling effect would be if it's too easy for the patient population. So everybody's doing a great job. So doing even greater isn't going to be measured because they already got all 10 points on that scale. And then we also want to look at the effects of motivation, try and reduce the burden of testing. We don't need to make patients do 4 hours of testing at a visit if we can get that same information in 10 minutes. And then we, as evaluators or physical therapists or physicians, are also variable. Patients react to us differently. So how does that impact what we would select for an outcome? So pulling all of this information together, I wanted to use an example from one of our natural history studies and how we thought about some of these things in inclusion body myositis. So we were planning a trial. It was an ambulatory cohort, so all the patients could walk. And what we wanted to know was, what is the best test in terms of walking ability that we could use to measure change over time? So again, we were looking at an adult population, so we didn't have to think about, pediatric considerations. Walking was reported as being clinically meaningful for the group that we were looking at. But we wanted to know, our main question was, how long is long enough? The longer the test goes, the more attention issues we all have, whether you're really focused and motivated. Something that lasts 5 minutes is easier to pay attention to than something that lasts 30 minutes. So we looked at, next slide, please. We looked at walking tests. And I'm going to use the example of the the 6-minute walk test, which I think is something that a lot of people have heard about in clinical trials, and inclusion body myositis as well. So it's a test where you just walk down and back on a track of a certain length. Usually it's about 25 meters. And you walk as quickly as you can for that 6-minute period of time, and we see how far you can go. And then we look at differences over time. And people often ask, where did this 6-minute walk test come from? So it was actually developed for the Air Force back in the 60s. There were publications looking at, could this work? Was it feasible? They actually looked at the 12-minute walk test in this cohort. They standardized the procedures, and so they were using it for about 20 years before Dr. Butland said, do we really need 12 minutes? It's kind of a long test. So he evaluated the 2-minute, the 6-minute, and the 12-minute walk test. And what he found, you can click, Nicole, is that the shorter times were easier. They were as reproducible, and they had less of a training role, so they were easier to implement than the longer test. And he thought that the 6-minute walk test represented a sensible compromise. So that was kind of the scientific rationale behind that 6-minute walk test. And so from there, everyone has been doing that 6-minute walk test. And so we wondered, do we have to do 6 minutes? So one of the other things Dr. Butland had mentioned was that there was less, it discriminated slightly less well. So the longer tests seemed to have more of a fatigue effect. But can we measure fatigue in a shorter test in a patient population that has difficulty walking and some muscle weakness? So we looked at our neuromuscular cohort of patients that did the 6-minute walk test and those that did 2 minutes, including inclusion body myositis. And what we found is that on the 6-minute walk test, patients kind of decline within those first 2 minutes. So that's what's on that x-axis. You see the 1, 2, 3, 4, 5, 6. That's the minutes of the test. And we see that same decline in the first 2 minutes. What we also see on the 6-minute walk test is that they kind of plateau after those first couple minutes, whether that's from fatigue, they kind of get into their rhythm, boredom maybe. We kind of see this plateau over time. So we weren't sure that those extra minutes were really giving us more information. And then if you click, it looks like I have some animations on here. They looked, Dr. McDonald out of UC Davis in California actually looked at the 6-minute walk test in a cohort of children with Duchenne muscular dystrophy. And what I like about this graph is it really shows the consistent speed that these children walked every minute. So that's pretty much a straight line over time. We don't see a lot of speed up at the end. Everybody kind of walks the same distance. We also wondered if a fixed distance, which I'll talk about a little bit later, could be more useful. Because again, whenever we see a finish line, I think we're more motivated to get to that finish line as quickly as possible versus kind of that abstract walk as fast as you can in this amount of time. So we tested this in a patient population with inclusion body myositis. So we had 67 patients that came and did kind of our battery of testing. And I put the graph here of our 2-minute walk and our 6-minute walk. So again, on the B graph, you'll see there's that little dip in performance in the first 2 minutes. But the distance, the speed that they walked in the 2-minute walk test was pretty consistent. And what we found was that patients with inclusion body myositis walk at a consistent speed. You guys are great at motivating yourselves. You know how fast you can walk before you're likely to fall or trip. And that's the speed you walk. What we also found was that when we looked at different measures of strength, so table 3, which is a little small on my screen, shows different muscle groups that we tested in the hips, the knees, the ankles, and these correlations just relate the performance of those walking tests to those strength measurements. So something that's about a 0.4 or 0.5 is significantly related, but it's not explaining, it's not a one-to-one correlation. Because we wouldn't really expect one muscle group to be 100% correlated to walking, as it kind of takes a lot of muscles to do those tasks. But what we saw when we compared the 2-minute and the 6-minute is those correlations are really similar. There's slight numbers that are different, but they're not statistically different. Similarly, in table 4, we did other timed functional tests, which I'll talk about a little bit later, but the timed up and go, stepping up on some curbs, climbing stairs, And again, the distance walked in the 2-minute and the 6-minute were really similarly correlated, more highly correlated to those other functional tests. So we concluded that 2 minutes was really sufficient for walking, measuring walking speed in patients with inclusion body myositis. So the next test that we wanted to look at was a fixed distance. So it's something that's a little bit shorter. Again, we thought, do we really need just a 2-minute walk as quickly as you can sort of test? Or would we get better performance with a test of fixed distance? So the 100-meter is on that same track as the 6-minute walk test, and patients are allowed to run if they're able to complete that test as quickly as possible. So they go down and back and down and back, and we see how long it takes. We piloted this in a cohort of patients with Duchenne muscular dystrophy. But what we found was that across our neuromuscular disease population, a test that lasted about 1 to 2 minutes or 1 to 3 laps was the most highly correlated to those other strength and functional measures. So that's where we went with this 100-meter timed test. So what we found was that we had really consistent results. So patients, this test retest reliability is a measure we have patients do the test 2 times, and then we compare their times for those 2 tests. And so a 1.0 is as high as you can get. So you can see, depending on the patient population, we were at 0.95 and 0.99, which is great. A question we often get on these sorts of time tests where we allow patients to run is, you're probably going to have a higher risk of falls if you're encouraging patients to run. But what we found is we had a really low fall rate, and those falls anecdotally were actually in patients that were a little bit milder. And this was, again, a pediatric population, so they did not slow down on the turns and did kind of a skid fall and then right back up. So it didn't cause any injuries, and was a lower fall risk than we actually see in the 6-minute walk test. We also have the ability to collect norms and look at how patients are performing compared to age and BMI matched peers, which is great. Now, this test does detect differences between steroid usage groups, which is a kind of standard of care for Duchenne muscular dystrophy. So that was great. And then on the next slide, what we see is we can use this to measure change over time. So again, these were all patients that participated in natural history studies, and we could start to see, what does this population look like in terms of the amount of time it takes them to do this test, how this is compared to those predicted norms, and then how that can differ across patient groups. So BMD is a Becker muscular dystrophy, which has a similar muscle involvement to Duchenne muscular dystrophy, but it's a little bit more mild. So those patients tended to do better at an older age than patients with Duchenne muscular dystrophy. And then LGMD are the limb-girdle muscular dystrophies, and there's a bunch of different subtypes of those. But we can start to see kind of different trajectories across those subtypes, where some patients are more quickly progressive, some patient groups are more slowly progressive. And again, measuring this and kind of planning for these upcoming clinical trials allows us to tease this information out before we're investigating the efficacy of any compound. So to kind of summarize this example before I move on into discussing other outcomes more generally, is that outcome measures can change over time. So we are constantly learning. So what works today may not be the best thing in 10 years from now. So that's exciting. We constantly get to innovate and come up with new measures, but also build upon the knowledge that we have from other trials and stick with what works if it does. They also prepare us for these clinical trials, help us select suitable outcomes, and really continue to advance the field and give us a better ability to even make kind of prognostic statements in clinical care. So I don't know if I've stressed it enough yet, but natural history studies are really key for giving us as much information as we can have in both the clinical and research realms. So I wanted to shift a little bit at this point, now that I've convinced everyone that natural history studies are the greatest thing ever. I wanted to talk about some outcomes that have been validated in the inclusion body myositis population and also investigated, so would likely be used for clinical trials. So I wanted to start with strength because I think this is something that's commonly used clinically and in different research studies. It's often used as kind of a surrogate for early signs of treatment efficacy because we would expect to see early strength changes before we would see larger changes in function or participation in larger activities or quality of life. So there are different types or different ways to measure strength. I think the most common and what you've probably all experienced at some point is manual muscle testing. So this is frequently used by neurologists or physical therapists or whichever physician or care provider you're seeing in clinic, where it's kind of a quick assessment of muscle strength across a variety of muscle groups. This would be, we'll have you put an arm out and we provide kind of resistance to see if you're able to move that appendage through space against gravity, and then if so, if we can, when we're providing our resistance, if we can overcome the strength in your muscle, or if you're able to resist us. And you can go back to the previous slide, Nicole. So as that slide showed, I'm going to talk about kind of the pros and cons of each of these next, but I just wanted to give you an example of kind of what we're talking about, so we're all using kind of the same words, or if you hear these words reported in clinical trials, you kind of know what they're reporting. So handheld myometry is where we use these devices. There are a bunch of them, so they'll differ based on what clinic preferences or what a sponsor provides for a clinical trial. But these are actual devices that we would put against a limb and have you push against us as hard as you can, and we're able to measure kind of that maximal force. So we're able to do this with arm muscles, leg muscles. There's specific ones for pinch grip or hand grip. And so they all look a little bit different, but they give us more of an objective measure of strength. And then last on here is the fixed system, which is a fixed frame where it's even fancier and more sensitive, where we can measure down to the 1/100th of a Newton or a kilogram. There's force transducers involved, and we strap you to these systems. The kids often call this, well, and some adults, they call it the rack because they think we're going to stretch them. But it's providing this sort of fixed frame so a patient can pull as hard as possible, and that limb's not going to move, so we can truly get their maximal effort. Next slide, please. So on this slide, I wanted to talk about when we're thinking about strength measures, why we choose what we choose. So manual muscle testing, as I've said, is quick, it's easy, it's free, we can do this. People are really reliable, so I'm reliable with myself, but if you compare my manual muscle testing grades to our neurologist, they'll be quite different. We always joke that the physical therapists are right, because we spend more time doing them, but it does give us a nice overview of which muscle groups are involved. It can be really helpful for diagnosis because certain muscle diseases have different patterns of weakness. The problem is there can be some decreased sensitivity to change over time, which I'll talk about next. But moving on to handheld dynamometry, this is kind of the intermediate. So we get more sensitivity to change because we can record strength more objectively. So we get, depending on the device used, down to 1/10 of a kilogram or Newton, or maybe 1/2 of whatever unit of measurement. It's more cost efficient than a fixed system because they're usually at most $1,000, which is not super cost efficient, but much cheaper than those larger fixed frame systems. But it is more time consuming, and you do have to kind of maintain a certain position. And there are less muscle groups that we can test reliably with this measure. So often there'll be key muscle groups that we're looking at, like knee extension or flexion, which are easier to isolate. And then lastly, the quantitative muscle analysis is another term for that fixed system. It's really the most sensitive to change because we're recording really, really specific down to 1/100th of a kilogram sorts of measures, we can stabilize much more easily. But again, it's very time consuming, so we have to get all the straps in the right order, and it can be quite expensive. So on the next slide, I wanted to show some of the variability we saw again in our natural history study in IBM, looking at strength measures and why we don't use strength often as a primary efficacy outcome. So the graph with the blue bars shows different manual muscle testing grades. So there's a grade of 3 minus, a grade of 4, a grade of 5 minus. But what I think is important is that if you compare the 3 minus to the 4, there is quite a range of strengths associated with that same manual muscle testing grade. And this is due to a variety of factors, but often the amount of strength can be overlapping in patient groups, and it can be really difficult to distinguish and define that signal if you're just using manual muscle testing, because it requires a large jump in strength to go either between those two grades, or the amount of strength within those grades overlaps, so it can be a little bit challenging. Similarly, on the other graph that has the red and green, we can see that the amount of knee extension strength, for example, can vary dramatically in the amount of distance a patient can walk on the 6-minute walk test. Again, there are a lot of muscle groups involved in walking, so it's not just knee extension, but this is where kind of that signal can get lost because of the variability associated with strength. So next I'm going to jump into my favorite category, not to show my bias, which is function. So these are activities that are typically more clinically meaningful and are more broadly applicable to your daily life, and are typically what the FDA or other regulatory agencies like to see improvements on. So the first one I'm going to talk about is the timed up and go. So this is one where you have to stand up from a chair, walk around that cone, and come back and sit down. Like I said, it's fairly meaningful. There are some studies to show that this can be used to predict kind of fall risks, although it varies based on subgroup. But in our patient population with IBM, 80% of patients who could walk were able to get out of a chair with arms. However, there was a large proportion of that group, so 10% of those patients lost that ability in a year. So again, when I was talking about kind of ceiling and floor effects, some of these, the timed up and go can have a floor effect because getting out of a chair can become very challenging very quickly. So if you have a cohort that already has difficulty getting out of a chair, you may not be able to see small improvements in their ability if you're using this sort of an outcome. The next kind of category are balance measures. So again, falls are quite common in inclusion body myositis, and so reporting frequency of falls is often a go-to for companies to look at reduced fall incidence. But the problem with falls is it can vary over time. So what we see is, patients may fall quite frequently, and then they'll get a cane or a walker, and then all of a sudden their fall rate drops, or maybe they just had a behavior change and they walk less quickly. So it's not necessarily true that that amount of strength or functional ability is related to the number of falls. So this can be kind of problematic for a clinical trial. There are certain scales. There are a lot of balance scales. There's a Tinetti. I've got the Berg balance here, which I'm talking about. Usually these are scales that are kind of composites. They give you a lot of different tasks and give you this grade on an ordinal scale with a certain number of points. And then what we like to do is kind of predict that fall risk for a given patient population. Similarly, we evaluated stepping up on curbs or steps without using an assistive device in this population, which was really challenging. And it was actually quite sensitive to change and changes in knee extension strength, which I think I talk about later. And then one of the last items in the functional group that I wanted to talk about was stair climbing, because this is often included in clinical trials. But we do get questions from patients about the relevance and the meaningfulness of this particular activity, because our stairs aren't exactly the same. Our clinical stairs kind of look like this, where you have 2 handrails that are available, which isn't necessarily available in a normal household environment or out in the community. So patients are able to do this much better in the clinic than they actually can in real life. And we also have to consider safety. So patients that go up the stairs also need to be able to get down the stairs. And this is particularly challenging in IBM, especially in patients with really weak quadriceps muscles. It can be much more challenging to come down the stairs safely than up. So shifting gears a little bit to, I call them quality of life measures, but really they're patient reported outcomes, which regulatory agencies really like because they like to hear from the patients. And there are a couple scales that have actually been developed specifically for inclusion body myositis. One of them being the IBM functional rating scale, which is 10 questions. Your specialists may have asked you these questions. It covers a wide variety of tasks, so swallowing, hand, kind of fine motor skills. There's also gross motor activities like walking, climbing stairs. The pros to this are it's a limited burden of testing because you can complete this via an interview, or your provider may ask you to do some of these to demonstrate your ability. But the cons are, in a clinical trial, you may need to show changes across a lot of these different categories to actually show significant change over time. So if you have a treatment that potentially really improves swallowing, that can be great, but it could get lost. That signal could get lost in this scale because there are so many other dimensions in the composite scale. Similarly, the CIFA was developed according to the FDA PRO guidance. So there's kind of very specific steps that the FDA likes to see when someone's developing a patient-reported outcome. It was developed across a variety of studies that we participated in performing the kind of strength and functional assessments that were used to validate changes that we saw in the CIFA in an IBM population. It's similar, it has similar pros and cons to the IBM FRS because it does have that same sort of composite scale. But these are items that patients with inclusion body myositis reported were most meaningful to them. What's nice is that it's scored on a more broad scale of 0 to 10 points for each item. So in theory, there could be a little bit more sensitivity to change over time as there are more points you can get or potentially lose over time. So my last topic I wanted to mention before I open this up for questions is how, I've talked a lot about clinical trials and how we kind of think about all of these outcome measures, pros and cons, to measure change over time. But using all of these outcomes clinically, I think, is equally meaningful. So I think one of the things I often hear from patients is that they feel out of control. So you have this condition, you know you have this condition, but there's really nothing that patients feel they can do about it. So again, using our natural history study, we kind of modeled, we looked at key activities that patients, again, it was an ambulatory cohort, said were really important to them. So one was walking, standing up from a chair, and stepping up onto a community 4-inch curb. And we looked at the factors that affected the ability of patients to be able to do those to see if there was a place where we could intervene. So looking at the next slide, the first thing we looked at was walking tasks. So looking at our 55 patient cohort, there were a lot of strength measures that were significantly correlated with the ability to walk quickly. So your hip extensors or your kind of gluteal muscles, your quads, and your calf muscles were important in walking, which is not completely rocket science, but it is nice to know that those are kind of the key muscles that are making patients walk faster. And while we may not be able to truly exercise those muscles to build strength, I do think it underscores the importance of performing these functional activities to stay active, to keep these muscles moving and as strong as possible, as long as possible. But what we thought was most interesting was that body weight was significantly related to the distance that patients walk. And this is something, though not easy, this is something that's somewhat in patients' control. So for every 1 kilogram of weight, or 2.2 pounds that a person put on or had, they actually walked 1.2 meters less within the 2-minute walk test. So again, that's a short, it's a small effect, but if you think about 2 minutes is a short amount of time to walk, so clearly it's additive. And 1 kilogram is a small amount, but if it was 10 kilograms or 20 kilograms, then this starts to have more of a substantial effect. So understanding that this is impacting ability and can affect disease progression, it is something that patients can work to change. Looking at standing up from a chair, we found that elbow extension was the most significant predictor of ability. And why? Is because the IBM population has great compensatory strategies for being able to get out of a chair in the presence of significant knee extension weakness. So really using the arms, once the triceps got too weak to push up out of the chair, that's when that strategy or that skill was lost. So we often will talk to patients that we see are having more progression with triceps weakness. We talk about equipment prescription in terms of hydraulic chairs or seat elevators or different cushions and assistive devices that can make those tasks easier in the home and community. And then on the next slide is stepping up on a curb. So this was something that in our patients early in the disease that were starting to have more difficulty getting in and out of restaurants, or they were starting to look for curb cutouts, and it was really affecting kind of their efficiency with moving throughout the community. This was something that was really important to them, and they wanted to understand kind of what was that key factor that impacted this ability. And it was knee extension strength and age. So again, why? Unfortunately, our balance over time, whether we have a diagnosis or not, gets worse with age. So that's a factor we can't necessarily impact unless we find that fountain of youth. But knee extension strength then was the most significant predictor, and it was because we did not allow patients to use assistive devices for this clinical trial. So it's not something where they could use their arms to compensate. So it really is a task that requires your quadriceps. But if you do have access to a cane or a handrail or a walker or a caregiver, then this was a task that patients were able to do longer. So again, kind of breaking these things down and thinking them through and talking with patients about what options are available can really be helpful. So to summarize, if you haven't heard it yet, I will repeat one more time that I really think natural history studies are key to giving us as much information as we can possibly have to make better clinical care recommendations and better plan for clinical trials. We want to understand as much as we can about a condition and its effect on an individual and in groups. And it also gives us the opportunity to get your input so the patient can have a voice and tell us what is meaningful, what would be great if you could do, what isn't great that you are having trouble with. And these outcomes come in all shapes and sizes. So this was just a quick overview. I could talk about outcome measures for days or weeks. So they continue to change, and so continue to give your feedback to your providers so that they can get creative and continue to innovate to find better ways to measure you. And our goal with all of this is really to be as prepared as possible, because the worst case would be that we have a treatment that potentially could be beneficial and it gets thrown out because we didn't measure it correctly, or that we're giving bad clinical care recommendations because we're not really measuring something that's meaningful to the patient. So we want to be as prepared as possible so that we're giving you guys the best information that we possibly can. So with that, I will stop talking and say thank you.
Thank you, Dr. Alfano. That was a wonderful presentation. I wanted to take this time now to jot through our Q&A section. We do have quite a few questions, and I do know we are getting to the top of the hour. So I will go ahead and ask you a few questions here.
Okay.
To what extent or percent is the amount of exercise related to increased strength or endurance?
Yeah, that is a hard question. So that I will try to answer in not a vague way, but it really does depend on the individual. So what we find is there is a balance with exercise. So patients that keep themselves active, which differs again for every patient. So if you're able to walk, whatever that distance is, you can walk before you're overly fatigued. is really what we would encourage you to do regularly. If you're unable to walk, if there's another activity, so we have some patients that really like to do aquatic therapy or water aerobics where they can be in the water and kind of working their muscles, or we have other patients with arm ergometers and things like that. Anything that you're able to do, we would encourage you to continue to do that activity to get your heart rate up, get your muscles moving, and keep those muscles moving. Where we see problems are patients that don't listen to their bodies and push themselves too far, too fast. And those patients actually tend to get weaker faster. And then we also conversely see those that don't move. The muscles don't have the opportunity to maintain strength, and so can have a different progression. The amount of strength is a harder question to answer. So that one I'll have to unfortunately defer.
Okay. Here's another question. I have wondered if IBM progression can be staged. At any given point in my course, I could look back at the loss of specific function and subsequently find loss of others over the years. Do our function losses occur in parallel with those of IBM's? If so, might they be grouped in stage 1 or 2, etc.?
Also a great question. Maybe. So I do think there's kind of that typical progression where, walking activities get more challenging, then getting up off the floor is really hard. Getting up out of a chair is really hard. I don't know that we've formally staged these things, but I do think we expect things to kind of follow that typical pattern depending on how much strength is required for a certain activity.
This person was regarding the inability to rise from a chair.
In terms of staging that across?
Mm-hmm.
Yeah, that I don't think has been specifically looked at, but is a great question. I think we also wonder, again, as a physical therapy group, we have a lot of discussions about whether kind of this decline over time is truly a linear decline, or if we do see this kind of stepwise progression where maybe you've lost some strength, so you lost an ability, and then there's this kind of plateau phase, and then all of a sudden you reach some sort of critical loss of muscle that then results in another sentinel activity that you lost, so being unable to rise from the chair. I think it requires a critical amount of strength or muscles working together, and once we pass below that threshold, then that's when we see the effect. But again, unfortunately, that is individualized to person depending on your height, weight, all of those factors. So it's hard to predict for the individual.
Okay. Is the 6-minute walk test reflective without or with a walker?
So for most clinical trials, it is without a walker. Some trials will allow patients to use assistive devices, so whether that's a cane or a walker, but then they want them to use the same thing across the trial.
Okay. Can using elastic bands with various tension help at all or not very helpful?
It depends.
Okay.
So I would recommend having whether it's finding an exercise expert, so whether that's a physical therapist or a personal trainer. They are not going to be the experts in IBM because most physical therapists, frankly, and personal trainers or other, exercise specialists may or may not have heard of IBM, but that's where you are the expert in your disease and they're the expert in exercise. So you guys can both bring your brains together to make sure that everybody's staying safe and finding the optimal strengthening regimen. What I wouldn't advise is for you to just pick up some elastic bands and try something, because depending on, baseline strength, you could, do too much and potentially injure yourself. So it's nice to have someone to at least give you that home exercise program so we can ensure that it's safe.
Okay. And I know we are just now at the top of the hour. I just want to try to fit in a few more questions if we can. Is there an efficacy in using eSTEM devices?
There is not a lot of research in eSTEM across neuromuscular disorders. We aren't sure. E-stim is really used to kind of activate that neuromuscular communication. And so in a muscle disease, I wouldn't expect it to necessarily be useful from a theoretical perspective, because we may not be trying to kind of grossly build muscle strength and get those nerves talking to the muscles. And really doing active functional activity is what's going to kind of challenge your muscles more, where E-stim can be a little bit more passive.
Okay. Are range of motion exercises a good use of my weekly PT? I have no mobility, but I'm fairly limber.
It depends. So just going to PT to do stretches may or may not be useful. If you are working toward a functional goal, I think that's useful. Some of those activities can potentially be done by you or a caregiver at home, so may not be a good use of resources if the physical therapist is just stretching you in the sessions. But it is important to maintain kind of that mobility and limberness, because the stiffer your body gets, the more uncomfortable and the more pain that you can have. So there's kind of that balance between finding new ways to stretch yourself. But if it is kind of in that maintenance phase, maybe that's something that you could do at home.
Okay. Is there a point in the progression of the illness where physical therapy is no longer helpful?
Not necessarily. So the goal of the physical therapist is really to keep a patient as independent as possible. And this changes across kind of those phases of the disease. So, even if in periods of limited movement, there may be key tasks that are really important to you that you've just lost or have become more challenging. And seeing a physical therapist can help kind of problem solve to come up with either compensatory strategies or potentially find equipment that may be more beneficial. So kind of having that, we like to think of it as more of this kind of ongoing relationship where there may be times where you're utilizing PT more frequently, and then maybe you don't need us. But then you come back if things are harder or easier, and we can help problem solve and get you what you need. So I'd argue that we can be useful across the ability or the span of abilities, but the actual implementation over time may be different.
Okay. And it's 5:03. I will ask just two more questions. Are there any natural history studies presently adding any patients that you know of?
Dr. Mozafar is actually kind of leading some consortia, and he is would be the one to ask if he's currently enrolling. And so I know there are efforts underway to get some multi-site natural history studies going for inclusion body myositis. But the other piece to studies is funding. So that's also a piece that needs to be put in place.
Okay. And then is there any kind of treatment out there that is able to help IBM patients out of a chair?
There are no, medications that I would recommend. There are potentially interventions that we can do in terms of changing the environment to make things easier. But there's not necessarily a medication I can say, if you take this, that'll make your muscles stronger and you'll be able to get out of the chair.
Okay. All right. Well, we are 5 after, so we do have some more questions. So I will be putting those all together, and then we will be sending out answers to everyone's questions as soon as we are able. I want to thank Dr. Alfano so much for your time today. It was really informative, and I do want everyone to know that the email that you see on your screen, by all means, you can email your questions after this webinar to mdaengage@mdausa.org, and we will follow back up with you. And tomorrow's presentation will begin at noon Central Time. So we look forward to seeing with you all. Thank you, and have a great rest of your day.